Hello, I'm Manoj Karmakar. Welcome to yet another video on ISSPS TV. In this next video, Professor Vincent Chan from Toronto in Canada is going to share with us how you can perform a point-of-care gastric ultrasound. If you like any of our videos, do remember to like and share it with your friends. If you are new to this channel, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
Hello, everyone. Thank you for inviting me to participate in this webinar series on point-of-care ultrasound. I will be talking about point-of-care gastric ultrasound, how to use gastric ultrasound as a valuable tool to detect a full stomach and mitigate the risk of pulmonary aspiration. I have no conflict of interest to disclose. In this webinar series, you see how useful point of ultrasound is to assess the airway, to look at the diaphragm and the lung, to assess the cardiac size and function, the stomach that I'm going to talk about, and finally, the last lecture on the hemodynamic assessment for shock states. I think as you have heard repeatedly in this webinar, the key to success for any point of ultrasound application is keep practicing, keep scanning until you acquire the hands-on experience to capture a good image. The more you scan, the more comfortable and confident you become. So for me, I often practice POCUS examination after doing a nerve block procedure as a practice. This recent anesthesiology article reminds us that pulmonary aspiration of gastric content is still a major patient safety issue. The incidence of pulmonary aspiration is estimated between 1 in 2,000 to 1 in 3,000 surgeries. In this 12-year ASA closed claims, there are close to 2,500 claims, and out of this, 5% of the claims belong to gastric aspiration. Most of these cases happen during induction of general anesthesia, but it can happen during regional anesthesia and MAC. Monitor anesthesia care when too much sedation was given. In many of these cases, the pulmonary aspiration is deadly. Close to 60% of these cases, patients die in this series. So again, it reminds us that detection of a full stomach is important, and we definitely need to avoid the risk of pulmonary aspiration because the consequence is grave. So take this case as an example. It happened to me, a patient came for emergency laparoscopic surgery because of bowel obstruction. The NG tube is already in place, it's drained already 200 mils. Do you want to know how much more gastric fluid there is in the stomach before induction of general anesthesia? So I scan the abdomen, and this is what I see. You can see something over here. There's some very dark fluid here. So there's still quite a bit of fluid in the abdomen, in the stomach, and obviously you want to do something about it. You may want to aspirate more before you proceed. Like any point-of-care ultrasound application, gastric ultrasound also follow the I-AIM framework. I stand for indication. It is indicated whenever we don't know whether there is any gastric content. A stands for acquisition. We need to know how to position the patient, what type of probe to use, what settings of the machine, also to make sure that we can capture a good image. Remember, a bad image is not going to give you any information. So this is the most challenging part of gastric ultrasound, is to find the stomach. And on average, studies show us you need about 30 practice exam followed by some expert feedback to acquire competency. So the learning curve is not very steep. I think it's very manageable. Again, if you need to practice if you have time after a nerve block procedure, just scan the stomach. I stand for interpretation. Obviously, we need to know the anatomy, the sonal anatomy. In this case, after we identify the stomach, we need to know what's in the stomach. Inside the stomach, is it air? Is it liquid? Is it solid? And also, how big is it? How distended is the stomach? Finally, medical decision making. Based on what we see, we want to decide what to do. If it's elective surgery, if it's a full stomach, obviously you may want to wait. You may want to also empty the stomach by some way. But remember this examination can be positive, can be clearly negative, not a full stomach, but also it can be inconclusive. You may not be able to find the stomach. So it's okay to conclude inconclusive if we cannot give you the right information. So obviously you're not going to scan every patient when they come for surgery, but there are patients that are at a high risk group and you want to scan. For example, you don't know what the NPO status is. The patient cannot give you the information, maybe due to language barrier, can have decreased loss of consciousness, or simply the history is unreliable, or the patient clearly has violated the NPO guideline. If patient has increased gastric pressure, such as in abdominal pressure, such as pregnancy and obesity, the flow of the GI tract is obstructed, maybe there is some esophageal disorder, gastric emptying is delayed, particularly after trauma situation or advanced diseases in the kidney, diabetes, liver, and also emergency surgery is one important risk factors to remember. And in this, again, going back to the ASA closed claim database, the 5 top risk factors are emergency surgery, GI obstruction, other acute intra-abdominal processes, morbid obesity, and GE reflux disease. But there are limitations of gastric ultrasound. Patients who have prior gastric surgery, banding, bypass, gastrectomy, obviously is not going to be helpful. Patient with large hiatus hernia, with diaphragmatic hernia, and about 2 to 3% of the cases, you just cannot get a good examination and they are inconclusive. So this is the first study we did to look at the gastric content and volume with the help of a radiology colleague. We begin to scan the stomach, and we realized that the pyloric antrum is the best place, is the most distal part of the stomach to scan. It's very consistent, it's superficial, it's consistently found in the epigastric area. And also you can scan through a very nice acoustic window through the left lobe of the diaphragm. The body varies in sizes. The fundus is the uppermost, usually filled with air. If you can see fluid in the fundus, the stomach got to be very, very distended. We know the stomach lie in different positions. It can be very vertical, but also it can be horizontal. Again, you'll find that most of the time the antrum is very consistently placed in the epigastric region, and that's why we do the scan in this way. So here the objective is to get a cross-sectional view of the antrum. That's where we want to examine. It gives us the valuable information. So we need to do a longitudinal sagittal scan in the midline. The structures that we need to recognize is most superficially the anterior abdominal wall. The deepest is the spine. You'll see a bright line with, after that is dark. You see the aorta lying on top of it with branches, the celiac artery and the superior mesenteric artery branching out. You see very obvious the liver, the left lobe of the liver. The antrum is very reliably inferior or deep to the liver, left lobe of the liver. Behind it is the pancreas. If you go a little bit more to the right side, you'll see the inferior vena cava. Again, the similar structures. The only difference is the aorta or the IVC telling you where the scan is. So this is an example of the midline scan. You see again very clearly the liver. You see some anterior abdominal muscle. You see this ring-like structures in an empty antrum over here, and some blood vessels. Again, this is another view giving you is a pictorial illustration. You see the aorta here is the deepest. You see the liver. Again, you see the antrum just inferior to it, and some blood vessels crossing. Vascular landmarks are important to recognize because you want to know whether you're on the midline or you're too much on the right side. And again, you see the aorta, the branches of the SMA, the celiac vessels, the splenic vein crossing behind the pancreas. How do you know whether it's the aortic and the IVC? If you look at the aorta, it's a single pulsation. It's very clearly the wall is very clearly demarcated. The IVC is also obviously a big vessel. You can see the double pulsation, and also is collapsible. So you know this is the IVC. This is the aorta right in front of the spine. If you use a linear probe in the to scan, particularly when the antrum is very close to the skin, you can see the five walls of the gastric wall, 5 layers of the gastric wall. The most innermost is the air mucosal interface with the content. The next one, the grayish area, is the deep mucosa or the muscularis mucosa. Then is the submucosal level. Then the next one is the thickest muscular layer is called muscularis propria. And finally, the outside surface is the serosa. And the muscularis propria is the muscle layer that we will see on the ultrasound when we use a curved probe. So when we scan, we can position the patient usually in 2 ways. One is supine, one is right lateral decubitus. The right lateral decubitus position is good because now the gastric content is going to gravitate towards the most dependent part of the stomach to the antrum, and it's going to distend the antrum. It increases the sensitivity of the test. But if the patient cannot lay on the right lateral cord, right lateral decubitus position, maybe due to pain, due to trauma, you can also put the patient in semi-recumbent position above 45 degrees. That would be second best. For the probe, usually we use a curve 2 to 5 megahertz probe in adults. For pediatrics, you can use a linear probe. Any one less than 40 kilogram, you can use a linear probe. So once you put the probe in the midline between the xiphoid process and the umbilicus, you may like to rotate the probe a little bit in order to get the best view of the antrum, because the stomach is not always lying vertical. It may rotate a little bit one side or the other, so it's gently rotate a little bit to get the good cross-sectional area of the antrum so that you don't overestimate the antrum size. So this is what the empty stomach looks like. It's going to be flat. It's going to be ring-like. Again, you are seeing the ring is the muscularis propria. Inside is empty. So either it's like a bull-eye round or it's quite flat. That's another image. You can see again is the antrum is inferior to the liver. It is very dark ring, the muscularis propria, the mucosa outside, and the stomach is empty. There's no content there. Next, the stomach may be filled with air. Air, we know what it looks like. It's a wall of bright image here, and you cannot see what's inside because blocked by the wall of air. Liquid is easy to find. Liquid is dark. hypoechoic or anechoic. His dark one is like this, is easy to find. Sometimes this is like carbonated fluid, or it is when you drink, you can also trap some air bubbles. So you will see something like this. We call this the starry night appearance. So usually the gastric volume a normal gastric volume after fasting can be up to about 1.5 mils per kilo, about 100 mils in a 70 kilo person. That is quite normal. What happens when it's filled with milk? Milk is giving you this appearance. It's liquid, it's hyperechoic, it's quite homogeneous, but you can see it moving around inside the stomach. For solid food, once you have eaten, you're going to have a lot of air in the stomach. So you will see a lot of bright area, and it's going to coat the upper part of the stomach, and you cannot see what's inside. After you wait a bit, the air is settled. Now you're able to see inside. Is usually, again, hyperechoic, heterogeneous with food particles inside that you see. So you can do a qualitative assessment, just eyeballing, just like a cardiac examination. Eyeballing, if you see nothing in the antrum when the patient is supine or in the right lateral decupitous position, we call it grade 0. When you see nothing when the patient is supine, but you see something in the right lateral decupitous, we call it grade 1. Grade 2 is when you worry about the patients you worry about. You can see the stomach both supine position and also in the right lateral decupitous. You know, in this case, there's got to be more than 100 mils in the stomach. Otherwise, you can do it also quantitatively. You can measure the size of the stomach by doing the two-dimension measure, two-dimension, and plug in the equation. Or easily you can use your ultrasound machine software program to trace the outline of the serosa, and you can give you the cross-sectional area of the stomach. To me, this is the most important study we did to really quantify the amount of fluid inside this cross-sectional area. So we have a correlation between the ultrasound cross-sectional area of the stomach and the actual gastric volume. We asked the patients coming for gastroscopy to drink 6 different volumes of apple juice. We scan them immediately to capture the ultrasound image to calculate the cross-sectional area. Then they are being scoped, and then the gastric fluid is aspirated. Now we have a good correlation between the two. We use a mathematical model, develop this for fluid, for right lateral decupitous position and non-pregnant patients, and we come up with this table. Remember, the shaded area is the safe zone, less than 100 mils, but for a 20-year-old patient, a 7 square centimeter is when it's more than 100. For 40-year-old person is 9 centimeters square. For a 60-year-old, you notice it's 11 centimeters square. And for a given cross-sectional area of the stomach, you notice that the volume is higher in the younger age group than an older age group. So it is age dependent. We also recently did another study to confirm that the diagnostic accuracy of gastric ultrasound is extremely high. The volunteers come in either have a full meal or have clear fluid more than 1.5 mils per kilo. And out of these 40 patients who has negative empty stomach, we got 1 false positive, but for 40 with truly positive full stomach, all of them are captured. So it's extremely high sensitivity and specificity to differentiate whether a patient has full stomach or not. So how is it going to help with a medical decision? I think it's one of the common application of gastric ultrasound is a patient who is coming for elective surgery and has violated the NPO protocol, you don't know whether to delay surgery or not, this is the best time to scan. If you scan and find that patient has solid, definitely doesn't matter how much it is, how distended the stomach is, you consider that as high risk. You want to wait. If it's a fluid, you want to know what the volume is. If it's more than 1.5 mils per kilo, more than 100 mils, you consider that as a high risk. Either you wait to proceed with general anesthesia, or you decide to give the patient some medication to increase gastric emptying. And you can scan again to make sure the stomach is now empty to safe enough to proceed with general anesthesia. For emergency surgery, you know the patient has a full stomach. This patient had bowel obstruction, need emergency surgery. I think the question is, can you do more to empty the stomach before proceeding with induction of general anesthesia? Perhaps you can move the NG tube a bit to further empty the stomach before you proceed. And this is a real case. This is before I suction the NG tube further. I move the NG tube around in and out in order to empty the stomach further. This is after. You still see that there is some fluid inside, but substantially less. Some of the things that I learned over the years, I noticed that the stomach is not always superficial, is not always inferior to the stomach. You can look at this stomach. If you scan in a certain way, it's actually very deep. It's very quite a lot more capillate. It's easy to see here because it has fluid, but without fluid, you may have a hard time finding it. So always don't only look superficial, you may have to look deep. Obviously, the antrum has to be anterior to the vessels, anterior to the pancreas. And what happened here when you scan and you cannot find the stomach? What do? Well, the first thing I do is I look and see how much of a liver I see. If this is a very little liver, perhaps I'm scanning too far to the left. So I start to move a little bit more to the right. I see more left lobe of the liver, and now I can see more. Finally, there are times that I really struggle. I cannot see the stomach. What I do is I put the patient in the right lateral decubitus and wait. If there's air in the way, it's going to flow up. Now I'm able to see it better. Sometimes the colon is in the way, and you can sit the patient up a 45-degree angle. And you may gently massage the epigastric area and hope the colon would descend and get out of the way. And finally, if I really don't know, I will cheat and ask the subject to drink a little bit of fluid, because fluid is so easy to identify. Keep the patient in the right lateral decubitus and wait to see where the liquid appears, and that's where your stomach is. Also, there are other things that may look like stomach as you scan. And the stomach is over here, but you see something moving very quickly and peristaltic wave in this area. That can be the small bowel. The way I tell is I ask the subject to take a breath in, so the liver descends, hold the breath. And if you hold the breath, you still see active movement like this, that got to be a small bowel, and the stomach usually does not move so actively. So other patient populations, I do not do pediatric, I do not do obstetrics, but I can only, other people do and probably can give you more information. Studies have shown that, again, consistently, you can see the stomach in pregnant ladies. This is empty, what empty antrum look like, and antrum filled with liquid, antrum filled with solid. The difficulty here is obviously the gravid uterus is big, is going to push the stomach high up towards the liver, and you'll have a smaller acoustic window to scan through. So you need to practice more. According to the literature, you can use this number 9.6 centimeters square as the cutoff point for a gastric volume of up to 1.5 mils per kilo. For obese subjects, we do quite a bit in our center. When the patient is in the right lateral decubitus, that would pose a difficult time to scan. Someone may have to hold the abdomen, the extra tissue up so that you can scan the right lateral decubitus. Clearly, the antrum is going to be deeper and there's more adipose tissue superficially. Pediatric, unfortunately, I don't do it, but it should be a nice patient population to scan. You can use a linear probe and the image should be easier to identify, it's clearer since it's this linear probe. Again, a table has been created to map out, to correlate the gastric volume and the antrum cross-sectional area. So I hope I have briefly reviewed the usefulness of gastric ultrasound using the AIM framework, indications whenever you don't know what's inside the stomach and how much is in there. Acquisition, always scan, use the aortic level as the landmark, scan in the epigastric region, both in the supine and the right lateral decubitus position. You are able to tell either it's full, empty, or in some cases is inconclusive. You have to accept that. And finally, medical decision, if it's elective surgery, you may want to delay if it's full stomach, or you also, if it's emergency surgery, you may want to further empty the stomach before you proceed. This is Dr. Anna E. Perlis at our center. She has done a lot of studies on gastric ultrasound, and these are some of the useful resources online that you can visit. So thank you very, very much for your invitation and the opportunity to speak. If you have questions later on after the webinar, you can approach me at this email address. Thank you.